Good afternoon. Thank you all for joining us for this first webinar that we're doing in a school nurse webinar series. So we are going to get started here. Now that it's 2:30, we may have some people joining us, but our first webinar is on childhood screening and HPV immunizations. Just a quick note for those of you joining by phone, the phone number is right there with the webinar ID. And we just ask that all of you keep your phone or computer muted for the webinar, as we are going to be recording this and hopefully posting it on the website soon. If you have any questions for any of the presenters throughout the duration of this webinar, please type it in the question and answer box that's located in the top left-hand corner of your screen. Feel free to put questions in there at any point, and as there will be time, we hope to get to them. If there's not time at the end of the webinar, we will be sure to send that out via email after the conclusion of the webinar. So just a quick note about the agenda for today. We will be talking about the background of the Life Course webinar series project that we're presenting today. We are going to have a presentation on childhood screening, a presentation on HPV immunizations, and then we're going to talk about the implications for school nurses and how you might be able to utilize this information in the work that you do every day. We also want to let you know that we are doing this webinar series in conjunction with the Iowa School Nurse Organization. So they are going to be providing the CEUs through this webinar series, and more information about how to obtain the CEUs will be included at the end of the webinar. The objectives for this webinar is that you as school nurses will be able to discuss the latest data regarding adolescent well visits and HPV vaccination utilization. At the conclusion, you will be able to identify at least 3 resources related to the subject matter, and to identify 3 talking points for bringing it up with the youth population that you may serve. To get us started, we wanted to talk a little bit about the Life Course approach to promoting adolescent health in Iowa. So Life Course is a theoretical model that takes into consideration the full spectrum of factors that impact an individual's health, not just at one state of life, but through all stages of life, from birth to death. A group of individuals at the state and national level have looked at data and pared down the indicators included in the Life Course theory to 59 indicators. The indicators vary in a variety of categories, including childhood experiences, discrimination and segregation, community well-being, and economic experiences, just to name a few. As part of this project, the Association for Maternal and Child Health Programs, also known as AMCHIP, they wanted to know how states were using the Life Course metrics. The state of Iowa was chosen to participate in this endeavor and created a project using these metrics. Our state team here at the Department of Public Health decided to propose a project focusing on the adolescent health indicators. By utilizing an intra-agency group of individuals who work on adolescent programming, we decided to create a deliverable with school nurses in mind. We pared down the big list of 59 indicators to include the top 12 we thought were most important to highlight that positively affect health outcomes later in life. Now, we know that there are many other topics and indicators that could have been included, but for the purposes of this project, we really wanted to look at the more preventive behaviors and not include too many factors. And so what we created is an interactive tool for school nurses to use with youth, focusing on the 10 to 18 population. So this tool is interactive in the fact that when you hover your mouse over one of the arrows or indicators, there are some talking points that pop up. These are talking points for you to use when you're talking with a young person about that topic. It doesn't mean you have to ask each question or bring up each statement, but it's to be used more as a guide. The color of the arrows for each indicator correlate to the Iowa-specific data related to that measure. If the arrow is green, it means that Iowa as a state is improving or better than the national average. Yellow means there's little to no detectable change, and red is that we are getting worse or worse than the national average. Also on the front cover of the page, there are directions and tips to use, so we'll be sure to send it out again after the webinar for you to look over it. For each of the 12 topics that are included on this tool, If you click on the arrow, you'll be taken to a page specifically for that topic. So each topic has 3 sections, and we wanted to give you more information that would help you when working with the adolescent population. So the 3 sections that are included include talking points. So again, like I said, these are just suggestions for talking about the identified topic with youth. There's a section on each page for supplemental information. So it's other information that we thought would be useful for you as a school nurse to know about. As you can see on the slide above, the one for childhood screening has information about Hawkeye, has information about those who might qualify under Medicaid, and just what's included in a well visit. And the third section is additional resources. So we have linked to other additional resources for you to access, whether it could be data, current trends, or other things you might find useful. And also, the last couple things that are included on each of the pages are current Iowa-specific data. It's the points or trends for each topic. So this is the measure that we looked at as part of the life course metrics. And most of the topics also have an infographic included. As you can see, the one for HPV is included right there. So you will find these 5 things for all of the 12 indicators on the main page of the interactive tool. So we've worked with Melissa Walker as the school nurse consultant on the development of this project, along with our Adolescent Health Collaborative at the State Health Department over the past year. A pilot program was completed this past spring with several school nurses in the Des Moines area. And the feedback found that the school nurses thought the resource was an effective tool to engage adolescents in conversations about topics that affect their health, and that it should be shared with students and parents as applicable. So this webinar series that we're offering is based off of this project. Each month we will feature 1 or 2 indicators to look at a little more closely. Since September brings many of the students back to school, we thought it would be appropriate to start with 2 of those main topics: childhood screening, adolescent well visits, and HPV immunizations. So our first presenter in this series is Annalisa Pearson, and she is a child health nurse clinician with the Iowa Department of Public Health.
All right, thank you, Addie. We are going to jump right in to the gory details here. I thought it was almost October, so I could have free reign to do that. So we're going to start out with some Iowa Child Death Review team. I was asked to do some Iowa statistics. So this is the most recent report from the Child Death Review team. So over the past 5 years, we've really seen a pretty significant continuous decline in our child deaths. We had 85 total deaths in the adolescent age group, which for us here, since it's the Child Death Review team, it does stop at 18. It doesn't go all the way to 24, as we typically see in our other stuff that we talk about for adolescents. We had 5 male teenage homicides, which is, so while we're seeing a decrease in our accidental deaths, we saw a pretty big spike in our homicides this year. This was the highest that we've seen since 2008. 2 of those were careless use of firearms to like a couple of friends playing with guns and accidentally discharging those. We have an unsolved case, 2 gunshot wounds with unknown assailants, and unfortunately 1 strangulation by a parent with some mental health issues. We also had 8 teens die in motor vehicle crashes. I wanted to point this one out. We had additional motor vehicle crashes, but this was 8 teens driving with intermediate driver's license. We only had 1 fatality with a teen who had their full license, and then we did have 2 teens driving with no license that were killed. And I just wanted to point out that while we are seeing a decrease in overall accident fatalities, 2011, we did have 8 ATV-related fatalities, so that's something to continue to keep an eye on and continue to educate students about. Suicide is a pretty important topic for school nurses. Since it's hard for me to remember that we are no longer in 2012 when I talk about these things, so I'll have to back up a little bit. So from 2009 to 2010, the total number of suicides doubled, and then it continued to increase into 2011 and remained high in 2012. Again, it's important to kind of look at those numbers, though. We really are talking about 17 children, so it's not a huge number of kids, but a huge impact for those communities and families, obviously. The statistics here don't match, so I have a call in to the child death review team about this. They reported in one area that there were two 12-year-olds included in the count, but those kids are not accounted for anywhere else in the death report. So it's possible that we had two 12-year-olds in 2012 that also committed suicide. 13 males, 4 females, which is a higher proportion of females than there were in 2011. Majority of the teens who are dying by suicide are in the 15 to 17-year-old group. And in 2012, suicide was the second leading cause of death for Iowa teens. So while it's not a huge number of kids, if you look to the graph on the side to the left there, you can look at, more 25% of our kids across the time span are feeling sad or hopeless. About 15%, 15 to 12% are seriously considering attempting suicide, and around 5% have attempted suicide one or more times. So we can move a little bit off the mortality statistics and look at something like teen pregnancy. In 2011, close to 2,700 Iowa teens aged 15 to 19 gave birth. So compared with their peers, they have significant life impacts, as you all know. So when we look at something like 17 deaths by suicide, or even just the total number of deaths at 85 versus 2,700 young ladies being impacted by giving birth. We have seen a significant decline in the birth rate between the 90s and 2010, declining at 33%. However, we are seeing a continual climb in our STI rates, our sexually transmitted infections. Half of those are occurring in people 25 and younger, and 1 in 4 new STIs occur in our teens. So we're seeing, just under 8,000 right now, or back in 2011. As I said, again, I'm going to be speaking about 4 years back all the time and thinking it's the present. And just under 1,000 gonorrhea cases in our 15 to 24-year-old population here in Iowa. So it's also important to think about health disparities. So African American, American Indian, and Hispanic adolescents, especially those living in poverty, experience worse outcomes in a variety of areas, including obesity, teen pregnancy, tooth decay, and educational achievement. We also see disparities somewhat between urban and rural, although when we look at the Iowa data, according to the National Health Survey, Children's Health Survey, it's not as large as you would traditionally think here in Iowa. So we've looked at a quick snapshot of some of the morbidity and mortality data, as well as things that have an impact, a negative impact on adolescents in Iowa. So I want to have us look now at our data related to adolescent well visits and see how we are doing as a state. And we're also going to look at it actually by county and age for our preventive well care visits. This is all Medicaid data that we'll be looking at, and that's all that we have access to. So we're going to start first with ages 6 to 9. And overall, while we're not going to be looking at the specific counties for the kids 3 to 5, the overall rate is about the same for our 3 to 5-year-olds and our 6 to 9-year-olds. We're right at about 69% of our kids, Medicaid kids, getting their well preventive exams annually, and 68% for our 6 to 9-year-olds. So you might want to find your county on there and see how you're doing. But we're going to move through this kind of quickly, but we'll be posting this so you can do a better comparison later, and you can have a little competition with your neighboring district. So then as we move up to age 10 to 14, you can again see that we start to see less purple counties. You can start to see that we see a little bit more orange. we dropped down to 62%, so it's not a dramatic difference, but it is definitely less kids getting in for their annual well exams. And then you might think that we would continue this decline, but we actually see some of our counties doing quite a bit better, but some of our counties are actually doing quite a bit worse. So that it's kind of interesting because the map looks quite a bit better at this age 15 to 18, but where our counties are doing worse, they're doing a lot worse. And so we actually, we go up a little bit to 65%. So our 15 to 18-year-olds, we're doing a little bit better than we do the 10 to 14s, which I think is just interesting. And I think it could be a very fascinating listserv conversation or breakout sometime, or if you have a dinner together sometime, you might want to discuss why is it that we do better at 15 to 18 years. So, and I tried to look at like where kids would be going to college to see if that might be it, and that didn't really seem to jive either. So, but then when we move to our 19 to 20-year-olds, we significantly drop off, and you can see the large amount of orange counties and the increase in red counties. So we have very few purple counties, but you can see, which I think is due to population, we have low numbers that for the first time up in the northwest quadrant, we have some purple going on up there, which I think probably just has to do with population. Not that I don't think you're doing an amazing job up there, but so we overall are at 45% for that age group. As a state, overall, for all kids 0 to 20, we are at the state average of 70%, and where we would like to be is at least 80%. So we have a long way to go, especially in some of those older teen populations. So this is a little graphic depiction of that same information. You can see we're at 90% for those under ones, and then it just kind of keeps dropping off from there, except for that nice little blip at 15 to 18 that I'm sure you guys are going to have wonderful, rich philosophical discussions about. Here's the world's worst infographic, but I tried. So about 2 out of 3 adolescents, so this is national data. So I just showed you the Iowa data. Nationally, overall about 2 out of 3, so 66%. We're at 70, so we're maybe a little bit better. Kids will go to teens will go to the doctor or their healthcare provider for a well visit annually. And but only 1 out of those 15 visits are for preventive care. So that's including, that 66% is actually including sick visits as well. So if you look at it that way, we're actually doing quite a bit better in our Medicaid data. And then that last statistic is that only about 1 in 6 visits overall includes any preventive guidance. So if you put together the sick visits and the well visits, only 1 in 6 are going to even include any preventive types of information, screenings, anticipatory guidance. So even when adolescents are going in for a well visit, they may not be getting things like screenings or anticipatory guidance, those kinds of things. So that's, again, another place where school nurses and public health can be trying to fill that gap. So they're kind of getting just the basic in and outs with the healthcare provider. So let's talk about what an adolescent well visit is and should look like, because I think a lot of folks don't know. So we'll breeze through some of this first stuff quick. So it should be a comprehensive unclothed exam. The parent or significant other should be asked to leave, because that's the perfect time during the unclothed exam part for the provider to get into some of the more sensitive topics. Exam components that are especially relevant during adolescence, according to the American College of Preventive Medicine, include height, weight, and BMI status, the skin, breast, genitalia. Those are also some of the same areas that come up as barriers for why teens don't want to go to the doctor. And then I added in oral health, just because that's something Bright Futures really pushes and something that we know that we need here in Iowa. So here is the Iowa EPSDT Care for Kids health maintenance recommendations. So these are what is paid for by Medicaid, what we recommend. This is the gold standard here in Iowa for what kids need. I took out the little kid parts and just left the 10-year-olds, the middle childhood, and adolescent pieces. So this I'm primarily giving you as a reference. We're not going to go through everything, but nutrition should be assessed at every visit, oral health should be assessed at every visit, mental health assessed at every visit, immunizations assessed at every visit, anticipatory guidance given at every visit. And then you can see that there are other screening tests and those kinds of things that are recommended at different intervals. So some of those screenings, so depression screening, we want to be screening for major depressive disorder or clinical depression, not just the blues, not just typical teenage angst. So we're going to go through some of these screenings. These are things that where I think that some of you can be gap filling or just noticing as nurses that professional awareness and making recommendations for referrals and those kinds of things. So the recommendation, all of the next like 10 slides or so are all going to be the United States Preventive Services Task Force recommendations, the current clinical guidelines. So it is recommended that we screen adolescents who are 12 to 18 years. There is not enough evidence to support screening children 11 years and younger. And for those 12 to 18-year-olds, they're really only recommending that you screen if there's adequate systems in place for diagnosis, treatment, and monitoring. Recommended tools are the PHQ-A, which is the PHQ adolescent, and the BEC. Please note that this is the 2009 recommendations, and they are under review. So, and that should say 2015 draft, not 2013. So these are very likely to change. Substance abuse, there is insufficient evidence to support screening for alcohol in adolescents. So that's important to note. They do recommend screening adults for engaging in riskier hazardous drinking. So tools to be used are the audit or just simply asking how many drinks they're having per day, or have you ever had more than 4 or more than 5, or how often are you drinking 4 or 5, whether you're male or female. I have to be honest and say that I left this on here probably because it's a sacred cow and not because it's the recommendation. It's hard for me to swallow that we're not screening. So yeah, it should probably go at the end where I put a lot of things that we're not recommending, like scoliosis and all of those. So up front there, that it was a sacred cow that I didn't move to the end. Tobacco use, and then also let me back up to substance abuse. So for no one is it recommended that we are doing illicit drug use. So pregnant women, adults, or adolescents, there's insufficient evidence to show that it is beneficial and will change behavior. So tobacco use, primary care clinicians, so they're more talking about doctors and the primary care nurse practitioners, those kinds of things, than they are school personnel or public health personnel. That they include education or brief counseling to prevent initiation of tobacco use among school-aged and adolescents. So again, that would be something that if you have a concern and you can recommend that they see a physician and that you can be networking with your healthcare providers about the importance of tobacco use. Sexual health has 2 recommendations. We have one around the actual physical screening for STIs and then one around counseling. So all men and women, non-pregnant women under 25 should be screened for chlamydia and gonorrhea here in Iowa. If they have any additional risk factors, multiple sex partners, men who have sex with men, and most teens are having new sex partners and maybe having more than one sex partner at the time of exploration. No judgment there. So they may very well fall into a category that also needs to be screened for HIV and syphilis infection. We are seeing a resurgence of syphilis here in Iowa. So that is something to be aware of. Pregnant women should be screened for all 4 at their first prenatal exam. We are not screening for herpes, HSV, in asymptomatic adults. They're recommending against that. Here's the intensive behavioral counseling intervention. It is shown to reduce the likelihood of STIs in sexually active teens. It's a moderate magnitude benefit, reduces risky sexual behavior, and increases the likelihood of condom use. Intimate partner violence. Go ahead and screen asymptomatic women of childbearing age 14 to 46. There's a whole host of recommended tools there. I'm going to leave discussing needed immunizations to Kelly in the next presentation. Blood pressure, insufficient evidence for screening. Scoliosis, it is actually not recommended to screen for. Obesity prevention, this is another one of those that is under review. So the current recommendation is to screen children 6 years and older for obesity and offer them or refer them to comprehensive intensive behavioral intervention to promote improvement in weight status, but it is under review. Testicular cancer is not recommended. Skin cancer, it's recommended to counsel adolescents about their UV exposure, but there is no recommendation about screening, cancer screening like the visual screening. Anticipatory guidance, I said earlier, to be done at every visit. Here's like 5 categories of things that should be covered, could be covered according to the American College of Preventive Medicine. Here's some tips for addressing unmet needs. If you ran out of time or you didn't have answers for the teen that day, they came in for one thing and you kind of needed to prioritize some other things. Here's our MCH screening centers. We have 22 of them across the state, so they cover all 99 counties. Clearly, that's not useful for you right now, but it will be useful when you get the slides. They can do depression screening, substance abuse screening, intimate partner violence, STIs, primarily if they're a health department, will they be actually screening for the STIs, pregnancy screening, and then they have a host of direct care services. So if you're looking for a referral source for teens who may not have a primary care physician or healthcare provider, they can serve as a referral for you. I would counsel you to find out about your MCH services in your county because not all of the MCH service providers provide all of the different services. So if you're banking on them providing an intimate partner violence screening for you, and then so you refer someone and then you find out that that's not a service that they offer, that's going to be frustrating for all involved. So you'll want to know in advance what your local MCH agency provides. And I'm going to leave the importance of school nurses to Melissa.
Thank you, Annalisa. Our next presenter that is going to be speaking is Kelly Smith, and she's a nurse consultant here with the Iowa Department of Public Health. And just a reminder that if you have any questions that you want to ask Annalisa, or for any questions that might come up for Kelly, just be sure to include those in the question and answer box up on the top left-hand corner of your screen.
Okay, thank you. So I'm going to discuss the human papillomavirus vaccine and all that it entails, some of the statistics that surround it. Most females and males at some point in their life will be infected with HPV. There are 100 different strains of HPV. About 40 of those strains infect the genital area. It is the most common sexually transmitted infection. By age 50, 80% of women will have been infected by at least one type of HPV. It's estimated that currently 79 million Americans are infected, and there are 14 million new infections every year in the United States. The highest rate of new infection every year is among people age 15 to 24 years of age. So certainly that 15 to 18-year-old population will be people that you're seeing in the school. Our bodies are amazing, and most people are able to clear the HPV disease and never know that they have had it. 9 out of 10 infections will go away by themselves within 2 years of infection. The only way most people are ever aware that they had HPV is by an abnormal pap exam. There are 4 strains of HPV that cause the majority of the problems. 66% of cervical cancers are caused by HPV types 16 and 18. HPV type 16 also causes a subset of vulvar, vaginal, anal, oropharyngeal, and oral cavity cancers in women. The other 2 types, HPV types 6 and 11, cause over 90% of genital warts in men and women, and most cases of recurrent respiratory papillomatosis. Annually, there are more than 11,000 invasive cases and 4,000 deaths from cervical cancer caused by HPV. The majority of cervical cancers that occur are in women between the ages of 35 and 44 years of age. So when you pair that with the previous slide where I said that the majority of people who are infected by HPV are in that 15 to 24 year of age category, you see that the onset of cervical cancer from HPV comes very quickly in that 35 to 44 year age range. Worldwide, there are over 500,000 new cases yearly of HPV, and HPV causes 91% of anal cancers, 75% of vaginal cancers, 69% of vulvar cancers, and 63% of penile cancers. It's also a major cause of oropharyngeal cancer, including the throat, base of the tongue, and in the tonsils. This is just a graphic that shows a breakdown of the cancers that can now be traced back to HPV. So you can see the darker color, kind of that bluish green, those are the males. They do have a large percentage of the genital warts, but the majority are in females. You can see cervical cancer, which is the next from the bottom in females, that is the second most common cancer that's diagnosed in women. Recent United States population-based studies conducted by the Centers for Disease Control show that 66% of cervical cancers are caused by HPV, and I think I've kind of gone through a lot of the numbers already. Every year in the United States, an estimated 26,000 new cancers are attributable to HPV, and about 17,000 in women. 9,000 of those are in men. And this map displays HPV-associated cervical cancer incident rates by state. So the darker the color are the higher rates, and you can see that those are clustered mainly in the southeastern United States. Iowa, we kind of fall in that 6.5 to 8.0 per 100,000 population. Every year, about 105 women in Iowa will develop invasive cervical cancer. So that's just over 1 woman per county in Iowa. And of those, a third, or 36 women, will die from the disease. From 2004 to 2008, Iowa had a cervical cancer age-adjusted incident rate of 6.9 per 100,000 population, which is very close to the national rate of 6.8. The age-adjusted mortality rate from cervical cancer for that same period was 2.1 per 100,000, which is slightly higher than the national average. Annually, an estimated 262 Iowans are diagnosed with some sort of HPV-associated cancer, but we know that 81% of those associated cancers can be prevented through the use of an HPV vaccine series. There are 3 brands of HPV vaccine that are currently licensed by the Food and Drug Administration. The first of which was licensed was Gardasil 4, which covers the HPV strains 6, 11, 16, and 18. In 2009, Cervarix was licensed, and that covers HPV types 16 and 18. Because 16 and 18 really cause the majority of cervical cancers, that one is licensed for females only, whereas the Gardasil brand is licensed for both males and females. And then just recently, in December of 2014, a third Gardasil or HPV vaccine, Gardasil 9, which includes 5 additional strains of HPV, was licensed. And the current recommendation of the Centers for Disease Control is that all 11 and 12-year-old males and females be recommended to get the HPV vaccine series. It is a 3-dose series. It's recommended to be given the first dose today, the second dose 1 to 2 months later. It must be at least 4 weeks after that first dose. And then that final dose should be 24 weeks after the first dose. The convenient thing about the HPV vaccine recommendation is that that comes at the same age that the meningococcal and the Tdap vaccines are recommended for adolescents as well. And we do know that as of January 2013, we had a new school entry requirement for adolescents going into the 7th grade or older to get the Tdap vaccine. So they kind of go hand in hand. That's a perfect time if you have students who are needing to go back and get the Tdap vaccine to get into 7th grade or older. You can also include in your messaging that it is a good time for them to get the meningitis vaccines as well as the HPV vaccine. So parents oftentimes want to know, why should my child get the HPV vaccine at age 11 or 12? They don't always understand why that recommendation is so young. In a few slides from now, I'll show you what some of the rationale or reasons that parents don't immunize their adolescents against HPV vaccine. And you'll see that among the top 4 reasons are that parents don't think that it's needed or necessary, or that they don't believe their child is sexually active. It's important to note that we don't wait until exposure occurs to give any other routinely recommended vaccine. So we don't wait until your child has been exposed to meningitis to give the meningitis vaccines. They are preventative measures. So at age 11 or 12 is a perfect time to give the HPV vaccine. The other thing that we know is that when we vaccinate children or adolescents at 11 or 12 years of age, it's going to produce a higher antibody response than it will when they're even 16 to 26 years of age. So getting that vaccine at a younger age will give them long-lasting immunity. We also know that the HPV vaccine is safe, it's effective, and it provides long-lasting protection. The safety studies show that the meningococcal vaccine and the Tdap vaccine safety profiles are right in line with the HPV vaccine. So there is no validity to a worry or concern that the HPV vaccine is any more dangerous for an adolescent than any other routinely recommended adolescent vaccine. Most common adverse events reported from the HPV vaccine are considered mild. And for serious adverse events that have been reported, there has been no unusual pattern or clustering that suggests that those events were caused by the HPV vaccine itself. We know that HPV vaccine works. High-grade cervical lesions have declined in Australia, where they have an 80% vaccine rate with the HPV vaccine in their female population. It is 90% effective against genital warts and between 99 and 100% effective against cervical cancers and their precursors that are caused by the types that are included in the vaccine. In Australia, I had mentioned that they had 80% of their female adolescents vaccinated. What they saw is that the portions of genital wart cases declined by 85% in their 15 to 24-year-old female population, who were the females being vaccinated. But they also saw a decline by about 71% among the males of the same age, indicating a herd immunity. Since the vaccine were first recommended in 2006, there has been about a 56% reduction in HPV infections among teen girls in the United States, even though in the United States we have comparably low HPV vaccination rates to the rest of the world at about 33%. HPV vaccines are long-lasting. Studies suggest that there is no evidence that immunity wanes after time. We see that it's very similar the way that it's made to a hepatitis B vaccine series. So, and we know that the hepatitis B vaccine series can produce immunity for upwards of 25 years. The HPV vaccines have not been licensed that long, so we don't know for sure that they'll last that long yet, but the evidence that we do have available indicates that protection lasts for at least 8 to 10 years at this point. And the studies are ongoing to monitor how long that effect will last. This graph just shows you how we compare to other countries in the world with vaccinating against HPV. You can see that in the UK, they are about 82% of their population is fully vaccinated. Australia comes in second, followed by Canada and the Netherlands at 50%. And then there we are at the bottom at 33%, unfortunately. One other bar that isn't shown on this graph is Rwanda. Before 2011, neither cervical cancer screening nor HPV vaccine was available in public health facilities in Rwanda. At that time, the First Lady of Rwanda worked with the public health system and with vaccine manufacturers and created an HPV vaccine program. And in April of 2011, 93,000, almost 94,000 Rwandan girls in primary grades 6 received the first shot of Gardasil vaccine and no out-of-pocket cost to them. And they did a 2-day school-based vaccination program, and the third day they followed up with girls who weren't enrolled in school. They repeated this for the second 2 doses. The first round of vaccine achieved a 95% coverage rate. The second dose, they achieved a 93% coverage rate, and with the third, again, 93%. So currently the vaccine coverage in Rwanda is 93%. Adolescent vaccination rates, both nationally and locally. This data comes from the Morbidity and Mortality Weekly Report, and this is 2014 data. And this just shows the completion rates in United States adolescents in the 13 to 17-year-old population. For Tdap vaccine, the United States average is about 87.6% of adolescents between 13 and 17 years of age have the Tdap vaccine, and in Iowa, we're at 76.7. Hopefully that will continue to go up as more adolescents get into that age range where it's required for school entry. The Menactra or Menveo vaccine, meningococcal, nationally 79.3%, and then in Iowa we're at 64.4%. And the national coverage for HPV vaccine is a dismal 39.7 for 3 doses in females and 21.6 for males. So you see, in comparison to the other 2 vaccines that are recommended at the same age, the HPV vaccine just pales in comparisons. And here's that slide that I was mentioning earlier about reasons why parents indicate they're not vaccinating their teen or adolescent. And the number one reason is that it wasn't recommended by their healthcare provider, followed by they think it's not needed or necessary. Their child, they might not believe, is sexually active, and then safety concerns or concerns about side effects. The not sexually active reason, I think, is always very interesting. There was a study that found that 46% of adolescent girls had vaginal HPV, so HPV detected in their vaginas, and only 70% of those girls reported that they had had non-coital sexual behaviors. So they're saying that they're not actually having intercourse, but somehow that virus is getting into their vagina. So we know that it's being introduced somehow. It's important for parents to understand that you don't have to have intercourse to be exposed to HPV. 33% of 9th graders have had intercourse, and only 6.2% have had their sexual debut prior to age 13. So that's why 11 and 12 is the perfect time to vaccinate against HPV vaccine. This chart just shows you how we're doing in Iowa at vaccinating against HPV, and this is data from our immunization registry, IRIS, as of December 31st of 2013. It's just a breakdown county by county, how we're doing. So you can kind of find your county on there. The darker the color, the better the rates. So in Iowa, we did apply for and receive a grant through the CDC's Prevention and Public Health Fund. And you may have seen billboards across the state just saying that you can prevent cancer. HPV vaccine is the key. And we got an extension to continue running those billboards. They were supposed to stop running this month, but we've got an extension, so we're going to continue to post those around the state. And then this is just an example of a poster that we created as well. And so these are free. If you, as school nurses, are interested in ordering these, you can come to our webpage and at the Iowa Department of Public Health and go to the immunization program subpage, and these are free of charge for you. We also have brochures that are available for you to use as well if you're interested in handing those out. We do have one question. Can you get the HPV vaccine after becoming sexually active? And yes, you can. It is recommended that you get it prior to sexual debut, but it is going to be effective against any type of HPV that's included in the vaccine that you've not yet been exposed to. We get that question a lot also. If you've had an abnormal Pap exam, can you go ahead and get the HPV vaccine? And again, yes, you can. Good question.
Thank you, Kelly. Again, if you have any additional questions, just keep posting them in the Q&A box. Our next presenter is Melissa Walker. She is the school nurse consultant with the Iowa Department of Education.
So now that we've heard about adolescent screening and HPV immunization with school health, for school nurses, we know that a couple things exist, that healthy students are better learners, and academic achievement in high school graduation conveys lifelong benefits for health. So some of the things that we know, a vast majority of Iowa adolescents are in school. School health services may be the only health system that reaches the majority of adolescents on almost a daily basis with preventative interventions when you look at school students being required to come to school for 180 days a year in Iowa. And then the school environment provides a positive health promotion opportunity to educate adolescents about health-related risks. We also understand that adolescents may be developing relationship with risk-taking peers as well during this time. So school nurses play a key role in capitalizing on opportunities to provide education on prevention during daily encounters with students and in the classroom with providing health education. So I'd like to go through just a few strategies that maybe you can incorporate in your school health services and nursing practice when working with adolescent students, and then also some strategies to promote parental and adolescent engagement in preventative health care, and also the education on the HPV vaccination. So when we look at student interactions, when you go to the life course approach, there are some talking points on that regarding health screenings. One of the things that you may want to say or ask a student when they come into your health office is, have you had an annual visit with your doctor? A lot of students may just come in for episodic care, or they may be coming in for medication or health service. We know that those relationships with their healthcare providers, just like the relationship that's built in the school setting between the student and the nurse, is important. And part of that adolescent's health is independence and self-advocacy. So stressing the importance of a relationship building and practice of open communication between the school nurse and the student promotes the student's ability to practice this positive health behavior with their primary care provider and their parent. They can take that practice home. One scope and standard of practice in nursing is health teaching and health promotion. So in addition to education, adolescents may use the social media and the internet to access health information related to whatever concerns that they have when they come into your office. So school nurses play an important role in providing evidence-based and supported information for students to access quality health information. Center for Disease Control and Prevention adolescent and school health website has tools and resources for school nurses to access on adolescent screening and HPV immunization. Additionally, the Iowa Department of Public Health Child and Adolescent Health website has information too that school nurses can incorporate. So another way to convey the message is you can use some signage in your office. Students look at things when they're waiting for their parents to come pick them up, or they might be waiting on you because you have a list of, or a long line of kids, you know, to care for prior to getting to them. Some of those messages can provide health preventative messages for HPV vaccine or school screening. And the nice part about that school signage is that it can be evidence-based material that you're putting on there, versus students who go to Google or to the internet to find advice regarding their health concerns. So when we look at that, starting the conversation at home, one of the things is making positive connections with parents. I know school nurses call parents daily for multiple things, whether they're providing updated health information of what's going on in school or concerns. A recommendation would be to open the door to communication by asking parents if they have any needs regarding their child's health or any interest if they'd like to be involved or volunteer in school health activities, services, or programs. You'd be surprised at some of the conversations that you may have with parents just by opening that door for communication. They may say that they do have a concern, but their child's not communicating with them regarding that concern, or they're not communicating, and you can be the avenue to kind of facilitate that between the parent and the child. I would also recommend using a variety of education materials. Just as you did that, did you know signage to start a conversation at school, you can do the same in a newsletter or a flyer home to the parent, or in basic face-to-face communication with phone calls, parent-teacher conferences, school events, meetings, or wellness fairs. Parent engagement in schools contribute to students' health and learning. CDC did a study that shows that students whose parents are engaged in their school lives are more likely to have higher grades, better student behavior, and enhanced social skills. All of those three things are important when you're advocating for health and as an adult, and moving forward into advocacy for self-independence. So wrapping up, preventative screenings and HPV immunizations have long benefits for the adolescent health. Going back to what Annalise had said, only I believe it was just 1 in 6 visits were for preventative services, preventative screenings for adolescent health. And going back to Kelly, 1 woman per county will get cervical cancer, and then out of that, 1/3 will die from that. I think that the HPV immunization is an important thing to promote in schools with students and adolescent health, along with the adolescent screening.
Okay, thank you, Melissa. We have just gotten done with our 3 presenters to talk about the adolescent well visit, childhood screenings, the HPV immunizations, and then some of the implications for you as a school nurse and how you might use this information. If you guys have any additional questions, please post those. We do have one that's up there from Laura Bailey. Why can't you get HPV vaccine after age 26? And we will have Kelly answer that.
So when they studied the vaccines pre-licensure by the FDA, they study them in specific age groups. And then when they're licensed by the FDA, they get licensed according to the age groups that they were studied in. So that's one reason. A second reason is when the Advisory Committee on Immunization Practices looks at vaccine recommendations, they look at what is going to be most cost effective and produce the most effect in disease reduction compared to the cost of the vaccine and the burden of disease per age. So we know that the older you get, the more likely you are to have come in contact with HPV, and most women and males have had their sexual debut by age 26 or before, well before. So you want to get that vaccine prior to then so that it's going to be the most effective. One thing that the recommendations do allow for is if you have someone who started the vaccine series at age 26 or 25 and then they age out of the vaccine series, you can go ahead and finish out the series just so that they get additional protection. And certainly providers are allowed to make off-label recommendations if they find a patient who maybe didn't have their sexual debut earlier and they don't think has been exposed, then that would be a good candidate for somebody to be vaccinated at a later age.
Great, thank you, Kelly. So with just a couple of minutes left, if you have any questions, feel free to post those and we can respond to those and post it out via email after the webinar as well. So I just wanted to let you guys know that this is the first in a series of webinars that we will be hosting throughout the year. So thank you for bearing with us as we have been trying to figure out all the technical aspects of this. And we will be doing one per month. All the webinars will be from 2:30 to 3:30 in the afternoon. We will be sending out flyers and registration information the month prior to the webinar, and that will be posted on the school nurse listserv. So you guys should have opportunity to hopefully view some of the other webinars. They will be set up very similar to this as well, with someone going in depth about the topic, talking about the how your role can maybe change or what to reinforce what you might be doing with youth as well. And so for those of you who are getting CEU credits, at the conclusion of this webinar, we will be sending an email out to all of those who attended with all of this information and with the 2 forms. So there are 2 forms that you will need to complete and you will need to submit payment to obtain the CEU. So all of the information will be included in the email, but the CEU request form will go to Chris Nave and the evaluation form will go to the Iowa Board of Nursing. So it's very imperative that you submit these within 2 weeks for the CEU request to be accepted. And so this webinar is being offered for 0.11 credits. And for those of you that are going to be obtaining that, it's $5 for those of you who are ISNO members and $25 for those of you who are not ISNO members. So again, we will send out that email, and if you have any questions, you can email myself. I guess I never introduced myself at the beginning, but my name is Addie Rasmussen, and I'm here with the Department of Public Health. So again, we just want to say thank you so much for being involved with this webinar and for sitting in. If you have any comments or you have any feedback for us, you can certainly email me as well, and we will take that in consideration along with any questions you might have for the presenters. So again, thank you very much, and I hope you guys have a good rest of the day. Thank you.